Thanks for having me, and happy to go over some of that. So, as you know, the evolut low risk study looked at patients who were low risk for surgical aortic valve replacement and randomized them 1-to-1 to either undergo surgical aortic valve replacement or transcatheter aortic valve replacement with the evolut valve. The study enrolled just over 1,300 patients, 730 in the TAVR arm and 684 in the surgical arm. And if you'll recall, when 850 patients had reached their 12-month follow-up, the primary endpoint of death or disabling stroke at 24 months was evaluated using Bayesian method, so a predictive method for what would happen. And all patients have now had their opportunity to complete their 2-year follow-up, and that was what was presented at EuroPCR earlier this week. What we saw in those was that patients continued to do very, very well out to 2 years. So when we look at the actual data, what we saw was that at 2 years, looking at the primary endpoint for death or disabling stroke, that occurred in 5.3% of the patients who underwent a transcatheter aortic valve and 6.7% who underwent a surgical, sorry, let me correct that. That was the initial Bayesian rates there. So the primary endpoint occurred, now let me pull up the primary endpoint occurred in 6.3% of the patients who underwent a surgical aortic valve replacement and 4.3% of the patients who underwent a transcatheter aortic valve replacement. So an absolute difference of 2%. Certainly met significance for non-inferiority with a p-value of less than 0.01 for non-inferiority. With regards to superiority, didn't quite meet statistical significance. The p-value was 0.08, so not quite meeting statistical significance. There had also been concerns in the low-risk patients about a possible catch-up, we recognize that in terms of absolute numbers with all-cause mortality or disabling stroke, that transcatheter patients early on tend to do better. But whether between years 1 and 2, there's a catch-up such that the actual surgical patients do better. And so we did a landmark analysis within this study, and we found that that wasn't the case for the evolut valve. So between years 1 and 2, with regards to all-cause mortality or disabling stroke, that occurred in 1.9% of the patients who underwent a transcatheter aortic valve replacement and 2.1% of the patients who underwent a surgical aortic valve replacement. Yeah, so when you look at secondary outcomes, there clearly are some differences, and you highlighted 2 of them that are in favor of surgical aortic valve, and that's pacemaker rate and greater than or equal to mild paravalvular leak. And so it's very true, right? So that is what that is. I think it's important to note that the incidence of moderate or severe paravalvular leak, which has been shown to have a clinical impact, was extraordinarily low in both the transcatheter arm and the surgical arm. But there is more mild paravalvular leak. And so what does that impact have over the long term? We'll have to see. We don't really know. Some studies have suggested it won't have much of an impact, but I think it's too early to draw that conclusion. What is the impact of having a pacemaker long term? We'll have to see there as well. Certainly, for young patients, batteries can wear out after a decade or so. So let's see what happens there. And I think similarly, there are advantages of the evolut valve in some of these secondary outcomes. When you look at hemodynamics or when you look at patient prosthesis mismatch, you see that the transcatheter valve is better. But how is that going to translate long-term? We also don't know. How are these different variables going to balance each other out? It's really why it's important to study these patients for a long term. Yeah, so the next stage is really to continue to follow these patients out. I think we can be very reassured that the patients are doing well at 2 years. I think we can also be very reassured that heart teams are doing an excellent job of choosing the appropriate patients to undergo these therapies. Certainly, this doesn't apply to 100% of low-risk patients. Some low-risk patients will have anatomy that's too small with regards to the sinus of Valsalva to safely undergo a transcatheter valve, or they may have coronary heights that are exceptionally low, in which case you want to give consideration. But heart teams are recognizing this. Heart teams are recognizing that in a small number of patients, there may be massive amounts of calcification, and the calcium really needs to be debulked in order to get an optimal implant. But for the majority of low-risk patients, I think we can be reassured here, but we need to see what happens. We need to see what happens at 10 years. We need to see what happens at 5 years. We need to continue to evaluate these patients and report on their outcomes.